بسم الله. بسم الله الرحمن الرحيم، والصلاة والسلام على أشرف الأنبياء والمرسلين سيدنا محمد وعلى آله وصحبه وسلم أجمعين. Welcome everybody. It's my pleasure to welcome our dear healthcare practitioner at the Directorate of Health Affairs of Jeddah and our colleagues practicing in other healthcare sectors throughout the kingdom and our respected audience. Welcome in the second session of the series on the topic of pandemic of coronavirus COVID-19, which has been coordinated and prepared with the support of the Director of Health Affairs in Jeddah, which aims to equip healthcare practitioners with the essential knowledge of therapeutic information and precautionary preventive measures necessary to limit the spread of coronavirus COVID-19. The second series will include the following. Today will be the first course titled COVID-19 Evidence-Based Medicine. And the second session, held tomorrow, intends to introduce the healthcare practitioner to the therapeutic protocol of the coronavirus and the most recent update in COVID management and treatment. In conclusion, I would like to thank and appreciate everyone who contributed to the preparation and coordination of these courses, from the Department of Academic Affairs at Jeddah Health Directorate and to the respected organizing company, our distinguished speakers, moderator, and our valuable attendees. We ask Allah that these courses achieve the desired outcome to aid healthcare practitioners in safe medical practices and to help us all to fulfill and execute our duties efficiently, to provide a distinguished health services to our citizens and residents. And now we begin the session with our distinguished moderator, Dr. Nisreen Justania, who will conduct our meeting today. Dr. Nisreen, who is a consultant in geriatric medicine, as well as Associate Dean of the female branch of College of Medicine in King Saud bin Abdulaziz University. She is a double board certified in family medicine, and she is a deputy chairman of Saudi Geriatric Society and Saudi Commission of Health Specialty. And she also has a fellowship in geriatric medicine, McMaster University, Canada. And she also has a Master Medical Education, King Saud bin Abdulaziz University for Health and Sciences. She is uniquely experienced in evidence-based medicine. Welcome, Dr. Nisreen, and thank you for joining us.
Assalamu alaikum wa rahmatullahi wa barakatuh. Bismillah wa salatu wassalam ala Rasulullah. I would like to thank Dr. Zainab, the organization committee and the scientific committee for including me in this really exceptional scientific forum. Now, when it comes to evidence-based medicine about something pandemic, newly known disease to the human nature, it's really difficult. Looking for evidence is going to be challenging in terms of quality of evidence, the number of evidence, and how to validate those evidence applied in real life. As you all know, evidence-based medicine is the integration between the best available evidence with the clinical expertise and patient's value. So in the pandemic status, best available is the best available now. Rushing, everyone is publishing about what's COVID-19, how can we prevent it, how can we treat it. Now, the clinical expertise, what we know is way much less than what we don't know about this disease. So we're trying to have our head together to have a scientific discussion that might have an impact on our patient care and in prevention. Therefore, with no further ado, I would like to introduce Prof. Lubna Al-Ansari. Prof. Lubna is a professor of family medicine. She is a professor of family medicine in King Saud University, Riyadh, Department of Family and Community Medicine. She has been there for a long time and her career is really impressive. She held a degree from the Royal College of Family Physician in UK. Also, she's a MRCGP certified. Prof. Lubna has a long relationship with evidence-based medicine. People who know and teach evidence-based medicine in Saudi Arabia, they know that Prof. Lubna were the one of the founder of evidence-based medicine, working a workshop, education for physicians, for healthcare workers. She has extensive experience in developing also guidelines. She had worked for the WHO as Assistant Director General for health metrics and measurement in the WHO. The year 2017 till 2019. I'm quite sure we will be hearing a lot of information that we can really utilize in our daily practice. So please join me welcoming Dr. Lubna. Thank you.
Okay, thank you very much. So am I starting first or Dr. Raja? Sorry. Thank you very much. I wonder if it is going, am I presenting first or Dr. Raja is presenting first? Can you hear me?
Dr. Lubna, mic mute.
Is it?
Yep. Now I can hear you. I can hear you now.
Okay, so it was muted possibly. So do you want me to start then talking about evidence, or are we going to hear about data first?
I think, excuse me, I thought we will start by Prof. Lubna, but Raja is here with us. Raja.
I can start.
Can I start?
I just want to clarify this.
Okay. Zainab?
Okay, if Prof. Lubna ready, okay, you can start. Okay.
Yeah, sure.
Okay.
Thank you very much, Dr. Nesreen, for the nice introduction. And in fact, it has been, I really would like to thank Dr. Zainab and all those working in Jeddah Health Directorate for the effort in organizing this series of educational sessions on COVID-19. And I would like to really appreciate that kind of effort, because it will, I'm sure it will have its dividends in the short term and in the long term, inshallah. And thanks for the nice introduction by Dr. Nesreen, and I'm really honored to be in a session with her and with Dr. Raja Raddadi. I've known them for a long time, and they are really great people with very scientific oriented approach, and with the rigor of selecting what data to present, what information to present. So I hope that the three of us will be complementing each other, and we will present a very nice session on the evidence that is related to COVID-19. I will start to share screen. Just a moment, sorry. Okay, I'm sorry. Okay. So I'll talk about the evidence base related to COVID-19 with special emphasis on public health measures, because I think at the end of the day, this is what matters most. It follows what is known as the 80-20 rule or the 90-10 rule, where it wouldn't cost much, but it would help a great deal in containing the epidemic and its spread. So thanks again to Dr. Zainab for all those who have worked in organizing this. And I would start with talking about evidence-based medicine very briefly, and then I would expand a little bit after that. But just to tell you that when you go into PubMed and search for evidence-based medicine, you would find that it has started only in 1992 as a concept of evidence-based medicine. And then the number of articles grew rapidly over the years. And now it is the normal. Here I was searching just for evidence-based medicine in the title and abstract. And the first article was written by Gordon Goyat and his evidence-based medicine working group. That was in JAMA in 1992. In 2017, 2 years ago, there has been another article by Gordon Goyat and Benjamin Joel and another guy, where they were talking about the progress in evidence-based medicine over a quarter of a century. So what I really want to tell you is that it has been a journey that is a little bit over 25 years. It's exactly 27 or 28 years. And I've been involved in evidence-based medicine in the mid-90s. And that it's an interesting story where I was really suffering for not knowing the best answer for my problems, the problems that I face. And then I came across an ad talking about evidence-based medicine. And then it was my journey. I started to teach it to residents and to colleagues and so on. And then we held the first workshop in the year 2000, and then Dr. Nuha Dashash and others from Jeddah group. I assume that possibly Dr. Raja and Dr. Nisreen were among that group as well. And this is where they have decided to start an EBM Jeddah group. And that was, it's just, what I wanted to say in this introduction is that it takes, we need champions in order to really have an evidence-based approach to what we're doing. And when we talk about Jeddah, and the champion we really had was Dr. Nuha and the nice team that she had. And then this was supported by Prof. Ba'aqil and many others. And that was the beginning for launching an approach that is very prominent when it comes to Jeddah publications and Jeddah decisions. So I don't have any financial conflict of interest, but I've been into evidence-based medicine for so long, as I have been telling you. And then it has been I'm presenting a study that I participated in as an author. It's a Cochrane review. And so that probably I'm biased in a way to the results of our review, but I assume that many of you would know what is a Cochrane review, what is a Cochrane review, and the effort that is being paid. So hopefully I'm not really biased in a way that is not proper. The outline of my presentation is to talk about what is evidence-based medicine, evidence-based healthcare, levels and sources of evidence. And then I will talk about the global response in terms of knowledge generation that has followed the announcement of a COVID-19 pandemic. And then the evidence base that is available for physical interventions that prevent the spread of respiratory viruses. And here I'm talking about our review and other reviews as well that are available, and the relationship between the evidence and the recommendations that came out. I would then talk about evidence-based policy making. I'm not saying it at the beginning because I want you to understand how policymakers and decision makers make their decisions when there is a kind of evidence, but it's not strong enough and even when there is a strong evidence, sometimes it's not followed. But I mean, the situation that we have in relation to public health is an eye-opener when it comes to assessing the evidence that is available. And then how can we move next? So just in case that there are some in the audience, some of you who are not familiar with the concept of evidence-based medicine, I will start with the basics, but I wouldn't take long into doing this. Evidence-based medicine, or EBM as we tend to call it, is a style of practice in which doctors or healthcare professionals, any healthcare professionals, would manage problems by reference to valid and relevant information. So the piece of information that we're talking about has to be correct and has to be relevant to what we are talking about. Sorry. Okay. This is the classical definition of evidence-based medicine. It is the conscientious, explicit, judicious use of current available, best available evidence in making decisions about the care of individual patients. بالعربي هو الاستعمال الواعي والمتعقل والحكيم في استخدام أو هو الاستخدام أو الاستعمال لأفضل الأدلة أو البراهين المتوفرة في اتخاذ القرارات المتعلقة بالمرضى. سواء بنتكلم هنا طبعا في definition, in this definition the definition was talking about individual patients, but we can talk about society and the community as a whole as well. And I always like this paragraph because it emphasizes on that this new paradigm was putting less emphasis on intuition, unsystematic clinical experience, pathophysiological rationale, which is logic, as sufficient grounds for clinical decision-making, and emphasizes more on the examination of evidence from clinical research. As throughout the experience that I had in the WHO, I came to understand that when we talk about evidence, we shouldn't be talking only about clinical research evidence. We should be talking as well about data evidence. And that is the part that will be covered by Dr. Raja, inshallah. So we're talking here about evidence that is coming from the best available research and the best available data as well. I'm sure that many of you are familiar with the 5 steps of evidence-based medicine, asking the question usually in a PICO format, and then looking for an answer, searching the literature, appraising what you find, and then applying it, integrating other components in the implementation, and then you assess how the outcomes that are patient-oriented have improved as a result of applying this evidence. The beginning was EBM because the concept was introduced by a group of internists, Gordon Goyat, Sackett, and others. But later on, there has been more physicians or healthcare professionals from other specialties, and therefore the term expanded to include evidence-based clinical practice. And then it was found that it's not only clinical disciplines, it's even the management, decision-making, policy-making. So the comprehensive term is evidence-based healthcare, but we still call it for convenience, and maybe because it's the generic term we started with as EBM, but we don't mean only medicine, we mean health in its wider definition. The use of evidence in healthcare has been there for 25 years, and it came in response to large and unjustified variation in clinical practice. It has been demonstrated that people are not treating patients in the same way as a result of significant levels of inappropriate care, more of over-diagnosis and more of over-medicalization, and the adverse effects and the induced ill health that probably patients would not have if we haven't diagnosed them with a condition and treat them with a medicine that we are not sure of all of its impact and effect on this patient. Anyway, so these are some of the figures that are related to EBM, the integration of the best available clinical evidence with expertise and patients' values and expectations, preferences, and so on. The 5 steps, the Cochrane collaboration, the cost containment, and also the levels of evidence, and especially when we're talking about interventions, as we are talking tonight. So we start with the experiences, but then we go into the observational studies and finally the randomized control trials and then systematic reviews of randomized control trials as the best evidence. But there are other pyramids for other approaches or other focuses of papers, but this one is for therapy. The MPM movement was considered as a disruptive technology. It was new and it was something that is very non-traditional. It was radical. It has challenged the standard practice, and it was a way or had a potential to democratize decision-making. So everyone, all stakeholders can participate if they know what is the evidence, including, of course, and probably it's not including, in fact, an important member of the healthcare team would be patients and patients advocates. The first decade of evidence-based medicine was about having the concept clarified and having some of the structure in order to practice it. But the second decade was manifested mainly by the development of tools, so many tools in order to help and support healthcare professionals in making decisions, evidence-based decisions. And as I'm sure that some of you are familiar with the 6S approach. It started as 4 levels of sources of evidence, but then it's expanded to be the 6 S's. So the basic level are those trials or those studies that are published in PubMed and Embase as the authors have prepared them. And then as we process, there are others who are familiar with the concepts of clinical epidemiology and started to process these primary studies in different ways. And the more useful and the more synthesized and the more concise the evidence, the better. So we can have synopsis as an abstract of a primary study, but it's a different abstract from the one that came with the original paper. It's an abstract that is based on the items that we consider when we assess the validity and the applicability of a paper, and then synthesis. And here we talk about the systematic reviews in particular, and maybe guidelines, synopsis of synthesis, and ملخصات حقت السynthesis, summaries. Here we will talk about a database that would help and that was integrated in a way that would help as a book, for example, like Dynamed, Up to Date, the BMJ, best practice, and so on. And then systems, and that when it integrates at the level of decision making, like in the medical records and so on. So, do we need evidence for a pandemic like COVID-19? It's a new thing. Do we have information even about it? And probably we do. We don't have information about COVID-19 in particular, but we have information that would help in decision making. But we need to work more on refining this. And in fact, when you look at all the databases that are available, you would be surprised by the amount of information and effort that was made to summarize and deduce and analyze all what is there. So this, for example, the homepage of Up to Date, and it tells you here that you can access the latest evidence-based information on COVID-19. And then when you click on that, you will find that it is categorized in a way that some of the sources of the information is relevant for clinicians, for the different specialties. And some of the information is, and this is also about the Q&A and so on, some of the informations are organized for patients, so patients can help as well, and not help, in fact, after all, we're treating them, so patients can make the decisions for themselves. And then there is other tools that they are testing maybe, but it has been shown to be helpful with MERS-CoV and others, like the normalized search intensity for COVID-19 terms in their database in Up to Date. So you can, and that is in collaboration with Johns Hopkins University. Dynamed, again, has a number of collections, summaries that are related to COVID-19. The Cochrane Library, this is the home page. And then the TRIP database, probably there's nothing in its homepage to alert you to COVID-19. But once you search for COVID-19, you will find that there are 884 hits, and they are classified, as many of you are familiar with this database, STRIP, Turning Research into Practice, and you can select the kind of evidence that you want to refer to and work on it. This is a relatively new database. The NNT.com, and I like it because it really synthesizes a lot of information and provides the bottom line. And then there is also a place where you can access their evidence bites, they call it, of COVID-19. So, and they put it in a format of question and answer. What is the overall case fatality rate of COVID-19? And that's the one-line statement. But then there is a summary of the evidence that has produced to this evidence bite. And then, of course, you can go and click on the original studies for which they have referred to. And these are other examples. How likely is someone to contract COVID-19 after close contact with symptomatic case? Can it be transmitted by asymptomatic people, and so on. MedCalc, I don't know how many of you are using these calculators, but even MedCalc is having a resource center, special calculators that are relevant to COVID-19. So I was really astonished and happy that there is an effort to support practitioners in making decisions. The Center for Evidence-Based Medicine and its summaries as well. Again, questions and answers, and there are plenty of them. This screenshot has been like 4 days ago, but there was one which I thought could be relevant to us. Is it safe for patients with COVID-19 to fast in Ramadan? And the answer was that, yeah, Ramadan is a month of so-and-so, but patients who have no symptoms, they can fast, but patients with fever and prolonged illness secondary to COVID-19 can become severely dehydrated. And then it brings you a verdict. زي قرار أو حكمت المحكمة بشيء معين, and then you can, that's a smaller thing to read, and then it provides even an algorithm on how to handle patients who are presenting with suspected COVID-19 type symptoms in Ramadan. So, and then that's the BMJ Coronavirus Hub that is widely useful. And then, and of course, the journal itself, the BMJ has many, for the last 4 or 5 weeks, all the issues are having something to do with with COVID-19. This one and this one talking about the health effects that have led to economic effects on the society and so on. The Lancet, no exception. Even when you go into PubMed and you will find this pink period, a pink part, which tells you that COVID-19 is an emerging, rapidly evolving situation. And if you want to access the latest public health information from CDC, that's the link. From NIH research, latest research, that's the link. There is a beta version of the whole PubMed, and then when you go through it, again, it reminds you that if you want to go directly to COVID-19, because it might take some time to index the articles and have them in PubMed. The Economist, again, it's talking, it has been a pandemic that has affected the whole world and the whole economy. So you can read about it, and there is also the Economist coverage. So this is updated like every couple of days of how the cases are spreading throughout the world. And then the Financial Times, and you can find so many information. Clinicaltrials.gov. How many trials do you think has been there registered for assessing usually either a vaccination or a vaccine or a new drug for management? I've made this screenshot on the 2nd of May. That was last Saturday, I guess. And as you can see here, there has been 945 trials that are registered with COVID-19. I was just searching for COVID-19 لحاله, and this is what I got. And they were distributed. The trials are coming from different parts of the world. And then I looked at it today, and as you can see, the number has increased. There are about 300 trials registered between خلال الأربع أيام هذه, in the last 4 days, and mostly are in Europe. يعني 300, about 150, 170 were in Europe, about 80 in the US. احنا يمكن كل region فيها 20 trial زيادة, which is not bad. I mean, but there aren't many trials on public health measures. And this is what I really think that we need to pay attention to. And I hope that by the end of my presentation, you come up with new thinking, and you can probably have the concept will be disseminated among this audience at least, and then we can disseminate it at a wider scale. This is the Cochrane review that I've participated in, and usually Cochrane reviews are updated every 2 years. This has been updated every year from 2007, and then 2009, 2010, 2011. And then for some reasons we stopped. We haven't updated it after that. So we decided with this COVID-19 that we need to work on it, because it has been ignored for a while, and it is important. The objective was to systematically review the evidence of effectiveness of physical interventions to interrupt or reduce the spread of acute respiratory viruses. These are the criteria. At the beginning, there used to be, it was inclusive of any study design, participants, any age, interventions, any physical intervention. These are some examples here. And then the outcomes are the death, number of cases of viral illness, absenteeism, severity, and so on. I wouldn't go into the results of the 2011, to be honest, because they were largely based on observational studies. When we decided to update this review, we decided as a team to use all the previous criteria except for the study design. For the study design, we decided that this version, 2020 update, will focus only on randomized controlled trials. Because there have been so many randomized controlled trials, and this is part of the team. It's still missing 1 or 2 of the colleagues. So anyway, it hasn't, the new update is not yet in the Cochrane. It's in Rivman, we're working on it. But as we had some data available, we decided that we decided that we would publish them and make them available for people to make use of. So I wonder how many of you are aware of medRxiv. medRxiv is a database that is produced by the BMJ and Yale University, and they do a little bit of screening, but they don't do a peer review. So it's a preprint version of the paper. And there is another also website or a database that is called preprint, and it works on the same concept as well. So we have published the results in 2 parts. Part 1 about face masks, eye protection, and person distancing, and part 2 about hand hygiene and other hygiene measures. Of course, it's an international team, but from Saudi Arabia, we have Dr. Ghada Bawazir, who's participating with us in this, and she's a wonderful systematic reviewer. Anyway, this is the PRISMA flow chart. It's incomplete, but in the 2011 version, there has been 23 included trials. In this version, we have 110. And that justifies why we don't need to look into observational studies anymore, because we want to provide decision makers, and including all of you, to use the best available evidence based on a synthesis of randomized controlled trials. This is the risk of bias of the included studies. And as you can see, maybe if you go here, you can see that we know that some studies have done very well into these criteria, but not the majority either we don't know, we couldn't find information, it's unclear, or we know, and it wasn't done in the best, the quality of those indicators was not as optimum as we, anyway. So that was the first analysis that we did, the forest plot. And I'm sorry if some of you are not familiar with forest plots, but it's looking at the cumulative here, or here at this diamond in Muayyan. And then you can see that mask versus no masks showed no evidence of effectiveness in terms of influenza-like illness or in terms of laboratory confirmed influenza. And then when we looked at other, at only those trials among healthcare workers, I was surprised to find that there are only 2 trials that have assessed the use of masks among healthcare workers, and pooling these 2 has not led to a significant benefit, to an evidence of a significant effect. And then that's using the masks, the surgical mask or medical mask versus the N95 respirators. And again, it's in all, whether we're talking about respiratory illness in general or influenza-like illness or laboratory confirmed influenza, it hasn't been demonstrated by pooling these trials that are available that there is a benefit of N95 over the regular, the surgical masks. And then when surgical masks were compared to other masks, but not the N95, like the cloth that is being advocated at the moment, we found only 1 trial that has compared them to cloth masks. And in fact, ILI, the influenza-like illness, was higher in the cloth mask arm compared to the medical surgical mask. So the relative risk was 13. The confidence interval ranged from 2 to 100. The adverse events associated with both types were more or less the same, and the general, which were general discomfort, breathing problems. The penetration of particles was highest with the cloth masks. Still, it's high with medical masks. Of course, it's not very high. It's almost not there when we're talking about the N95. But despite this information, which logically should lead to a better outcome for influenza-like illness and lab confirmed influenza, it didn't. So this is when logic does not produce the outcome that we were expecting. And it's for the decision maker to decide whether to believe the logic or to believe the evidence that we're having. Moving to hand hygiene versus control, hand hygiene has been shown to be effective for decreasing the occurrence of acute respiratory illness. Influenza-like illness, not very much, and lab confirmed influenza, but we used a composite outcome, and it has been shown to be effective using this composite. When we use this composite outcome, their hand hygiene compared to control was more effective in preventing the respiratory illness as defined by the composite outcome. Among children, we thought that children would show benefit, but it wasn't. It was the confidence interval was 0.84 to 1.01, so it's not yet significant. But hand hygiene was effective when it comes to absenteeism. So those who were using hand hygiene measures were more effective, more likely to not to be absent from school or from work. And then hand hygiene plus masks versus control, no demonstrable benefit. Hand hygiene and masks, but versus hand hygiene alone, again, it hasn't been shown to be effective. Soap and water, and I don't know if time would allow going into these details. But
Victoria, we have 3 minutes.
3 minutes, okay. So the results were conflicting. The same for surface and object disinfection. There has been conflicting evidence. Gargling with water, there has been only 1 trial which showed that gargling with water is effective. Vericidal tissues, inconsistent results. And then social distancing, there has been only one trial that has been carried out in Japan, and it has produced interesting results. I'm happy to talk about it in the discussion if you like. Eye protection, there has been no trials. So to sum up, we know that hand hygiene is an effective method. We haven't yet been able to demonstrate as a result of the available trials whether that masks, the use of masks is in any way is better than no masks, or N95 are better than surgical, or whatever. Nothing in relation to masks was confirmed so far by the meta-analysis and by pooling all the trials that we know of. There hasn't been enough studies even to assess these measures, and no trials to assess eye protection. For the PPE, there has been another review in the Cochrane Library, and the result was as follows: that some interventions may improve compliance with PPE or reduce contamination, like gloves and gowns, but most interventions were assessed in single small studies, so the evidence is very low certainty and the question remained unanswered. Is this how you feel now? Possibly, but this means that you are free to think and to make discoveries and to plan for the future. Of course, it is confusing when you see how the whole world is recommending the use of masks. But when you look at the recommendations of the WHO, and I guess I wouldn't have the time to go through this with you, but they acknowledge that we don't have evidence to support this, but it could be, it's harmful, it's harmless using the medical masks, so why not? And the same for all the recommendations. At least I was happy that they acknowledged that we don't have evidence to support these recommendations, and that these recommendations were based on logic and on observational studies, but not on RCTs. The same with the CDC. Maybe their recommendations were stronger in their language, but again, the reviews that were conducted, this was like a replica of the systematic review that we made, and they came up with the same conclusions. Face mask for the public during COVID-19 crisis. This has been an article written by Trisha Greenhalgh and colleagues. And those of you who have been into EBM for a long time, they know that Trisha is someone who's really, she has very important books and she has written extensively on the EBM and its use and so on. But still, she said in conclusion, in the face of pandemic, we still recommend that the perfect enemy may be the perfect evidence, sorry, may be the enemy of good policy. So the conclusion was that it's better to use the masks that are simple, cheap, and potentially effective. And she mentioned somewhere that not all the, even the authors have agreed on this conclusion, which I thought, and واستشهدت بالدراسة اللي احنا that we published in MedArchive, and that it is, since it is harmless, why not, till we get the optimum evidence. And these were the key messages. So now I hope that the audience don't think that this is a message or an invitation to forget about evidence. In fact, it's the opposite. It's a message for making more use of research and improve on it, and have the priority set well for what research to conduct. I mean, when we look at all the trials that are registered and there are nothing to be carried for public health measures, you know that the vaccines and the medications would have those who would support, but for public health measures, there's nobody to support. But to be on optimist, today there has been a meeting with the WHO EMRO with parliamentarians, and I was attending that meeting, and it has they have announced that they have put some like their priorities for research, and they are putting as a priority public health measures, but the budget is something in the range of $10,000. Not bad, but I guess the message is that absence of evidence is not evidence of absence. it's an invitation for having a better evidence for the future. I wonder if we will have, I wouldn't have time to talk about health policy, evidence-based health policy. I'll just show this one, that the decision makers, when they make decisions, evidence is only part, and if of their decision-making process. And if the evidence is not strong enough, then what would you expect them to do? It's again, this has been a slide by Walid Ammar, who's an AUB graduate. He's a member of the university there, but he's involved in politics in Lebanon. And he said, evidence, you at universities and research institutions are just thinking in terms of evidence. We have a lot to care for, and you need to modify the evidence to cater for all this in the future. So in summary, I guess that COVID-19 is not really a bad thing when we look at it from different angles, and it might be a blessing in disguise, and that it helps us to identify what we really need to work on, and that will have an impact at the health of our nations in the future. Thank you very much.
Thank you, Prof. Lubna. We will keep some time for the discussion. Now it's a great pleasure to introduce Dr. Raja Raddadi. Dr. Raja Raddadi is a consultant preventive medicine in King Abdulaziz University. She's assistant professor of preventive medicine. Dr. Raja, special area of interest is epidemiology, medical education, and chronic disease. She's a member board of the member of the Scientific Board of Preventive Medicine, the Saudi Commission for Health Specialty. She's a trainer in the program of Preventive Medicine Jeddah, and she's the vice president of Saudi Epidemiology Association. Dr. Raja will introduce the numbers that's local, our local situation, which is very important. Since how long we have been talking about utilizing the public health and the preventive medicine data to design policy and to try to make preventive measures also to help with the management of disease. I think the current epidemic shed light on the importance of this specialty and the data utilization. Dr. Raja, it's an honor to have you now.
Thank you, Dr. Nasir, for this nice introduction. And it's very difficult to talk after Prof. Lubna, after all of these evidence-based information. Now I will talk about a little bit very, very low level of evidence, just describing what is happening. And without documentation, without methodology, without peer review, we couldn't depend on that. Just we want to read what is happening in our local situation. Just I'll talk about the current state, interpretation of this status and challenges, and finally I will conclude. When we talk about any pandemic or any outbreak, we have a strategic objective to control this. And this is now the most important thing to do. And as Dr. Prof. Lubna mentioned, if we don't have a highest level of evidence, we can use any available evidence. So the first thing is to limit human-to-human transmission, including reducing secondary infection among close contact and healthcare workers. Second, to identify, isolate, and care for patient early, to address crucial unknown regarding clinical severity, extent of transmission, infection, disease option, prevention, and that was Prof. Lubna talked about. To accelerate the development of diagnostic therapeutics and vaccine. And one of the most important factors is to communicate critical risk and event information to all communities and counter misinformation. And this is very important for intervention to be implemented. And finally, to minimize social and economic impact through multi-sectorial partnership. My scope here is that I talk about the first and second one. So for any viral suppression, the virus suppression strategy and the most effective two strategies are development of vaccine and make this vaccine publicly available. And the second thing is to develop a therapeutic drug. In the absence of the vaccine and in the absence of the drug in this pandemic, we will go to the limiting number of the people who become infected and secondly, to carry out broad-scale serological testing. This is the New Zealand level of alert that adopted by the countries, and as we can see here, Saudi Arabia and Gulf region adopt level 3, that they want to eliminate the disease, and they implement a large scale of or run all the range of preventive measures, non-pharmacological measures, and a lot of what the Prof. Libna mentioned in her presentation. When we go to the Kermack epidemiological model and we want to apply this pandemic on it, we can see as we want to protect the whole population. The whole population are susceptible to this infection and nobody is immune. No vaccine, no treatment, and no any other way to protect the person. And we want to take in consideration few most important points in this scenario. The probability of meeting contacts per day is one of the most important things to address when we want to control this pandemic, and the asymptomatic incubation period and also the asymptomatic patient is most important to calculate the basic reproductive number. What is the basic reproductive number? Is how many people on average each infected person will in turn infect a fully susceptible population. And this is what we are looking for. As we can see here, COVID-19, the basic reproductive number is 2 to 3. Compared to SARS and measles, it's lower. Compared to seasonal influenza, it's higher. If you compare it with MERS COVID, it was less than 1. Less than 1 means that this infection is unlikely to propagate and make a large outbreaks if we control it. So if you want to work on prevention, we should look into our basic reproductive number. This is the global situation. As you can see, the American and European region reported the highest number of cases. And the transmission classification, according to WHO make their classification for the whole countries. The first level is no cases with no confirmed cases, and we will not show this in our table now. Sporadic cases with 1 or more cases imported locally, detected, cluster of cases, experienced cases cluster in time, geographic location, or by common exposure. And the highest level when this outbreak started to be uncontrollable is community transmission when experienced larger outbreak of local transmission defined through an assessment of factors including, but not limited to, large number of cases, not linkable to transmission chains, large number of cases from sanitary lab surveillance, and a multiple unrelated cluster in several areas of the countries. And finally, pending, when they pinned the classification of this country because there is a new evidence that it may be better or it may be transferred from, for example, cluster to community transmission or go back from cluster to sporadic. This is the classification for Gulf region. Saudi Arabia classified as cluster, also Bahrain, Kuwait, and Oman. Qatar classified as a community. That means the propagation of outbreak and increased transmission of outbreak more than clusters, and it's uncontrollable now. United Arab Emirates now is pending this week. This is the latest report on May 5. They want to reclassify into either community, and I don't know what they will classify it in the next report. The global situation, as we can see, more than 3 million cases, more than 200,000 deaths. Now, if we want to compare our region, Saudi Arabia reported the highest number of cases and Oman the lowest number. But when we take the population size in consideration, case per million, and we can see here that Qatar reported the highest number of cases and also Oman the lowest number of cases. This is to adjust for the population size. Regarding recovery rate, as we know, the global recovery rate is 33.2. As we can see here, Bahrain, the recovery rate is higher than the global rate. Kuwait and Oman comparable. Qatar, Emirates, and Saudi Arabia is lower than the global reported recovery rate, and it could be related to the definition of recovery in each country. death per million, as we can see here, the global rate is 31.9 compared to very low numbers in our region. 12 per million in Emirates, this is the highest one, and 2 per million in Oman. Here in Saudi Arabia, 5 per million. This is related to the young population, which make the disease very mild among the young population compared to the older population, which they experience a very severe and critical cases. As we can see here in Saudi Arabia, case per city, about 50% of the cases in Mecca, Jeddah, and Medina, 17% in Riyadh, and 12% in Eastern region, and other distributed all over Kingdom of Saudi Arabia. Now we'll talk about the testing to identify or to identify the cases and trace their contact. Testing is the most important tool to help us to control this pandemic. Where the capacity for testing is low, tested people are not representative of the wider population. So the reported number is much lower than the actual number, and the actual number could be asymptomatic cases, which may lead to propagation of this outbreak and increased number of cases because we didn't identify these cases and trace their contact. The importance of testing here is crucial. Testing is our window into pandemic and how it spread, help to understand the pandemic, and it's one of the most important tools in the fight to slow and reduce the spread and impact of the virus. Allow us to identify infected individual, tracing and quarantining of those contacts, and can help to allocate the resources and staff efficiently according to the distribution of the cases geographically, by age, or by nationality. We will not forget the natural history of the disease, and we can see when the patient becomes symptomatic and the duration from the exposure to the infectious agent and the development of symptoms. This is a crucial time for spread of infection. This time, it may be from 4 to 14 days. If we didn't trace the contact, identify the cases, we will not be able to control the outbreak. And this time is crucial for us, and we should work on it. The benefit of contact tracing, this is the first evidence that I will present in a published paper published in Lancet Infectious Disease among 400 patients from China diagnosed with COVID-19, and they traced their 400 patients, and they study their contact, 1,300 contact, and they conclude that the isolation and contact tracing reduced the time during which cases are infectious in the community and reduce a basic reproductive number. They compare the contact-based surveillance with the symptom-based surveillance. When we depend on when we ask the patient, if you have the symptom, come to us. In this way, we will miss a lot of patients. And those patients will become infectious and stay in the community, and they can spread the infection and become the outbreak become propagated. And as we can see here in this line, the proportion of confirmed case by real-time PCR is higher among when they use contact-based surveillance compared to symptom-based surveillance. Now, our statistics regarding testing. We have two most important indicators or KPIs to help us to know our progress toward controlling this pandemic. Number one is test per million. As we can see here, Emirates have the highest test per million, more than 100,000. For us and Oman, the lowest number of testing, and I hope that in the next week we will have more testing. The test is one of the most important problems internationally, the availability of the test. There is shortage in the availability of the test in all countries. However, the test, we will not forget that we use the test not only for identification of the cases, also for follow-up of the patient and to identify the recovered population. Test per confirmed case is one of the most important and sensitive indicator to help us to know our situation in this outbreak. However, the interpretation should be considered according to the population. For example, when I go to high-risk group population with a lot of cases detected there, I can see that it's very low. However, in the population with a low number of cases, it will be very high, but we can monitor each cluster alone. So for controlling the outbreak, we need to reduce our basic reproductive number. A basic reproductive number of 1.5, controllable when we trace 50% of the contact. If the basic reproductive number is 2.5, we want to trace 70%, and 90% of the contrast should be traced if the basic reproductive number is 3.5. So the delay between symptom onset and isolation had the largest role in the determining whether the outbreak was controllable. And when we reduce the exposure of the population, of the susceptible population, to the patient between the time of exposure to the infection and onset of the symptoms, we can reduce and try to control this outbreak. Another factor determining the size of outbreak, we will not forget the virus, virulence, genetic shift and drift, viability of the virus, and we have very scanty research on the viability of the virus after shedding the virus from the patient during the incubation period. And also the human factor related to immunity, age, sex, exposure, comorbidities, and their behavior or protective behavior, and try not to expose to the infected patient. And the most important thing now is the environmental, which bring virus and host together, indoor and outdoor preventive measure to reduce the chain of infection and reduce the exposure of the susceptible person to the patients. We will not forget the asymptomatic patient. A lot of study conducted on this, but we don't have a strong evidence whatever, because some studies reported that 5% will be asymptomatic. Some studies reported 20%. The majority of the study reported that 20% of the patient will be asymptomatic. But some studies, especially among children, they reported that about more than 80% will be asymptomatic, especially when they conducted this among children. So the measure to help to know pandemic is testing coverage. As we can see in the previous slide, we presented test per million, but it should be test per 1,000, and we didn't reach to calculate it as test per 1,000 population. And the second one, number of test per confirmed cases, which is the most helpful to monitor our progress toward tackling this pandemic. As we can see here, this is some countries, they reported the test per confirmed case. As we can see, it's reached about 1,000 per confirmed case. And here, as long as we have high test per confirmed case, that means we now tackle the outbreak and try to stop the propagation, provided that this applies to general population, not to strategic or high-risk strategy and selection of the high-risk group. How to determine asymptomatic cases? By screening. And as I mentioned, we depend on the test. So we can select target population is the strategic screening. Strategic screening that we will go to the district that they have the highest number of cases or population with, as we do now in Saudi Arabia, we are targeting the contact of the patient, but we need rapid and reliable tests. If we don't have a highly specific and highly sensitive test, we will miss the patient and we will not have a clear picture about the distribution of the disease. Availability of the test is one of the important factors. As we know, the whole globe, they need this test, and it's very difficult to reach to that now. Maybe during the next week, we will have a lot of tests to apply in our community. The challenges toward controlling this outbreak include, as we know, no antiviral, no vaccine. The basic reproductive number of COVID-19 is higher than SARS and MERS, according to our previous experience. Asymptomatic infection with potential to propagate and prolong this epidemic. testing sensitivity, specificity, and availability are another source of challenge that can help us to control the outbreak. And finally, we will not forget that the isolation of the suspected people in a single room is one of the major challenges. And if we start to make active surveillance and detect more cases, at that time, maybe we will not be able to cope for all detected cases to be isolated in a single room. In conclusion, control of COVID-19 can be achieved through a combination of measures in addition to other measures. I didn't go through management of the patient, infection control, and what will happen with the patient. I'm talking about the community transmission and control of the outbreak. So the most important thing is to identify and follow up the contact, rapid identification of the cases. As I mentioned, sensitivity, specificity, and availability of the tests are the key factors that can help us to control this outbreak. And research gap about COVID-19 should be addressed. Prof. Lubna mentioned a lot of research gap, mentioned a lot of areas that we should look for and to identify, and we should participate in the research activity internationally more and more to identify the evidence in our country and in our population. Thank you very much.
Thank you so much, Dr. Raja, for this very interesting information. Now we are start receiving questions, but I have a question. Now, how would you explain the recovery rate and the death rate in Saudi Arabia? It seems to be not really consistent with the global recovery rate and the death rate.
Okay. The recovery rate could be related to the definition of recovery. Some of the country, they define recovery when the patient have no symptom. Here, till now, we are using the definition that when the patient have no symptom and we should have 2 negative tests. So if the patient have no negative test, we will not consider and we will not say this patient is recovered. That's why our recovery rate very low. Maybe we need to change this to save the test also, because we are consuming our tests on follow-up of the patient to make that to identify the recovered person, and this is need to revisit the definition of recovery. Regarding the death rate, as you know, our population pyramid, the majority of population in Saudi Arabia and Gulf area are young, and this disease is very simple, and as we mentioned, with asymptomatic mild to moderate symptoms. That's why we don't have a lot of severe or critical cases. This in turn help the hospital to identify or to cope with the cases with critical condition, and they can cope with that. And so these 2 factors, the young population and the availability and of the bed in the health system, help us to reduce our death rates.
Okay, Dr. Lubna also will share us the answer for questions. There was a question earlier about the recovery. Do patients who are recovered from COVID-19 susceptible to have another infection with the same COVID-19 virus?
Well, I guess it's difficult to answer this question at the moment, but I mean, any kind of infection will provide some kind of immunity at least for 2 or 3 months, and then maybe things will be, the person will be susceptible. So we need to have the illness for a longer period, followed up, I mean, for a longer period in order to decide whether we're having a reinfection or not. But I think that we haven't heard yet of any case of reinfection, but we don't know what will happen in the future. Expectation is that very unlikely, but we don't know. We have to find the evidence for it.
Yes. I'm with Prof. Lubna said it's unlikely. I think it's unlikely. It's maybe related to the specificity of the test. This test could be non-specific, and they can classify one patient as have corona, and at that time he don't have COVID-19.
Okay. Another question here, are we applying home isolation for the suspected cases?
For the suspected cases, as we mentioned, home isolation, we can do that when the system couldn't cope with a lot of cases. So if we identify a lot of cases and we try to isolate the contact, it's very difficult, and we will go to that finally, but it's not recommended.
اوكي طيب السؤال ده بالعربي فقراه بالعربي. هل ينتقل الفيروس عن طريق الدم، خصوصا ان الفتره الحاليه في جميع الاشخاص بيتبرعوا بالدم. Now the concern is like there is a big announcement about all blood banks needing blood donation, and someone is concerned about getting coronavirus or COVID-19 through the blood transfusion. So what do you think, Dr. Lubna or Dr. Raja?
Well, I think blood banks usually are careful, and nowadays I don't think they wouldn't assess the blood donated for COVID-19. But what is known is that that it is a droplet or airborne infection, but it hasn't been raised that it is that this transmission can happen through blood transfusion. But I assume that this is a good question. We need to look for the evidence. But I would be very surprised if blood banks are not really testing the blood for COVID-19, and for as they are testing for other things. So and they are assessing the people who are donating. So most likely they are identifying those who have high white cells, for example, or something of this kind, so that they wouldn't take blood from them. But I don't have a definite answer for it.
Okay. Now there is a question about the seasonal flu vaccine. Do you advise or do you recommend it? And would it give some immunity against the infected, the corona or COVID-19? Would the usual flu vaccine help? Do you think so?
Sure. We advise to have an influenza vaccine, and as we can know, this is the best example to show us what will happen if we don't have a vaccine for any disease. Nowadays, we are conducting a study to see if there is a protective effect of influenza vaccine on this, but I think there is no enough evidence to say that influenza vaccine could protect from COVID-19 without evidence.
Okay.
Well, if you want me to comment,
yes,
there are Cochrane reviews as well about the vaccine in general for the effectiveness, its effectiveness in reducing the number of cases of influenza-like illness and lab-confirmed influenza. And the reviews have shown that among elderly or adults, that there is a modest reduction. So there is a reduction, but it's very modest. And it's up to the person to decide whether he or she would like to have been exposed to the vaccine. And given that the outcome is not very high as compared to those who are not vaccinated. But so it's a personal decision, but I wouldn't be for or against having the vaccine influenza. It depends on the person.
Okay.
It's not that it is very strongly recommended or strong effectiveness that we would go naturally for it. Like
for the purpose of COVID-19, yeah. But like
for COVID-19, I don't think that the vaccines that are available nowadays would be covering COVID-19 strain. It's a very new one. I don't think it would be there. So no, the answer is no.
احنا عندنا part 2 عن المانجمنت tomorrow، ففي شوية questions بس عشان لا يزعلوا اللي بيسألوا deeply في المانجمنت we will refer it to tomorrow's session. طيب السؤال الثاني، إذا التزم الجميع بالتوجيهات المطلوبة في الطب الوقائي والصحة العامة، فمتى المتوقع، كلنا نسأل السؤال، أن ترجع الأمور إلى طبيعتها؟ أعتقد كل يوم يجيكم ده السؤال.
It's very difficult to know now. As long as we are making active surveillance and we find this number of cases and we want to trace all this number of contacts, we couldn't expect, because a lot of factors play a role here. The testing of the contact, isolation, the availability of isolation rooms, and also she mentioned that the population will stick to the instruction. we hope in the near future we can overcome this pandemic.
This is a very important question, and there is always we think about the collateral damage that happened with pandemic. مثلا الإفكت على الكرونيك disease، الإفكت على ال usual clinic visits. فهنا في واحدة she's so concerned about taking her child to the primary health care for vaccination لأنه خايفة يجيله عدوى لو يروح. So how can we think about the risk and benefit؟ يعني هو شوية سؤال tricky. دكتورة رجاء، دكتورة لبنى، بروف لبنى، feel free to answer.
It depends. Well, most people are not visiting the healthcare facilities at the moment, so I don't think that it's not like the emergency departments. Even the emergency departments nowadays are not that busy, and therefore. When we're talking about a primary healthcare center, I would expect that the risk of contacting an infection is not as high as expected. All the public health measures are followed. رغم إنه ما في evidence قوي عليها، بس في social distancing، في the use of barriers، في so the chance of the child getting an infection, I don't think is really high. But if she's really worried, maybe she can ask for home care. I know that there are mobile units nowadays that are giving vaccines at home. إذا كانت ما هي من الvaccines اللي مرة urgent, maybe she can wait. She can consult her primary care physician whether she needs to take it now or she can wait for a while to get the vaccine to her child. But أعتقد إنه في مبالغة في الخوف من الريسك. ف she needs to decide on that.
ولكن
yeah.
طيب يعني هو we're so concerned about the kids not having the vaccine at the right time. دائما لازم نسأل our pediatrician about the risk of delaying those vaccines. If they said like the window is 3 weeks 4 weeks ما هي مشكلة. وزي ما قالت بروف لبنى إنه كل ال preventive measures لازم تكون في بالنا وإحنا رايحين نزور مركز صحي. طيب هو هنا في سؤال تاني كان بيتكلم عن إنه how do we as healthcare practitioners how do we protect ourselves و should we change المعدات من مريض للتاني. طبعا يعني this is in the policy. What do you think؟ يعني healthcare yeah.
Okay, so yeah, can you repeat the question? أبغى أتأكد قبل ما أبدأ أجاوب.
أيوه هو مكتوب بالعربي، هل يلزم الممارس الصحي يعني يستبدل جميع معدات الحماية الشخصية بين حالة وأخرى؟ So يعني السؤال in another way الممارس الصحي do they change the protective measures between the cases between seeing cases؟
There's nothing يعني على الأقل بالنسبة للريفيو اللي احنا سويناها هي it was mainly in the community. In fact, we couldn't find many cases about healthcare, many trials I mean about healthcare workers. واللي لقيناها كانت عن الهاند هايجين، عن الفيس ماسكس. لكن بالنسبة يعني I assume الشيء اللي يبغى له يتغير يمكن من مريض لمريض. بنتكلم عن الجلوفز مثلا. هنا ما يمكن في الريفيو الثانية لقوا دراسة واحدة مثلا عن الجلوفز. So it's difficult to say, but again, you can use your own judgment. We don't have enough evidence to come up with a recommendation يعني in any way الحقيقة. recommendations اللي أخذوها متخذين القرار كانت من باب الأحوط والحماية just in case وبناء على observational studies. لكن ما في شيء أكيد إنه لازم يتغير الجلوف بين كل patient to patient. But I would say بالنسبة للجلوفز لأنه you are touching patients بالذات إذا أحد بيشتغل في الإمرجنسي department you're touching a patient and then you're moving to another patient, so maybe there is a logic at least. لكن إنه if you're working in بالنسبة للماسك بالنسبة للجاون probably not exactly unless you're working in a theater surgical وهذا طبيعي بده يغير بين المريض والثاني يعني. ف just use logic because the evidence is not strong enough to dictate or to يعني recommend come up with any recommendation.
طيب, there is another question. Would someone catch a COVID-19 infection from a person who looks totally normal? Yani probably the question is if the patient is just carrier, they're positive, but they have no symptoms. Would he be infectious to other people around?
Well, maybe, yeah. ما أدري دكتورة رجاء تحب
Please repeat the question. I couldn't get it.
السؤال can someone get infected by someone who is totally healthy, has no symptoms?
Yeah.
Asymptomatic?
Yes, this is what we mentioned. This is the most important source of infection. This is the source of infection, and this is the most important point to address to control this outbreak. كل هذه propagated the outbreaks والcases from this source.
Asymptomatic, yeah.
Asymptomatic.
Which may range, as you mentioned, from 20% to 80% in different societies. So there's a chance, yeah.
طيب دكتورة لبنى, we need like 1 minute conclusion ودكتورة رجاء كمان, and we will be closing this nice webinar. Very
okay. The message that I would like to mention is that في الفترة الأخيرة كان في إعلانات لبحوث ممولة كتير من جهات مختلفة. But when they put the themes were mainly for vaccines and for drugs to treat the illness. And I haven't seen the themes covering the epidemiological aspects of the disease or the use of public health measures. And إحنا نعرف إنه درهم وقاية خير من قنطار علاج. So I would call for investing more and more in research in order to come up with the evidence that would help appropriate decision makers. يعني احنا الآن شغالين for a lot of social distancing مثلا, isolation. What if they are not, and we don't have evidence, it's on logic. لكن إذا عندنا evidence إنه maybe it's not that infectious, mixing 1 meter will be more than enough, ما يحتاج نجلس الموظفين كلهم في البيوت. That would save a lot of cost to the society. If we invested in this kind of research, ما راح يكون waste. يمكن يكون من أهم أنواع الريسيرش. آخر حاجة, أنا assume إنه within a year كل هذا الكوفيد 19 حيكون انتهينا تقريبا من أغلبه. السبانيش فلو كلها انتهت خلال سنة. Let's work for the future. بحيث إنه إن شاء الله طبعا let's work for the future so that if there is another epidemic in the future, we are
prepared.
Armed by, exactly, yeah.
Yep. رجاء, Dr. Raja, thank you so much, Prof. Lubna.
I support Prof. Lubna recommendation regarding that we need our own research. We have a lot of cases. We have a lot of cases, but we don't have resources to conduct research and have our own evidence. Second thing, maybe I will say my recommendation for the decision maker regarding studying the overall process of control now, what we are doing, monitor our progress in contact tracing and control of this pandemic, and plan a new strategy to make an intervention by increased testing, increase the definition of recovery, contact tracing, identification of the cases.
Okay. So thank you very much. To conclude, we had a great time hearing about the numbers, our current local situation, comparison to the international and the globe. Also the sources for evidence-based medicine regarding COVID-19 and how strong is the evidence using the evidence giving the fact that we don't have really strong, impressive evidence, but we're also applying the common sense and taking the precaution and the preventive measures. Thank you very much. I hope that would be beneficial, and we're looking for the second part. Thank you.
Thank you very much.
Thanks to you.